Hello everyone, this is our second video on anemia. It is part 1B. We're going to cover erythropoiesis, the causes of anemia, and we're going to define some key terms. So I have a question for you. What does the presence of an increased reticulocyte level in the peripheral blood indicate? Think about it for a minute. Think about that the normal reticulocyte count for healthy adults is 0.5%. So what does it mean? What is going on when that number goes up? Well, when there is an elevated reticulocyte count, that tells us that we have immature cells floating around, which means that red blood cell production is being stimulated. There's been a response or a stimulus in response to a problem, and so we're seeing more immature cells getting put out into the periphery. Remember that a reticulocyte is the last immature form of the erythroblast, and as the erythrocyte develops, the nucleus shrinks and we get more hemoglobin. So what you see in this image here are the slides with the little stain, and that's little bits of nucleus of DNA, and that's how we know those are reticulocytes. So they are immature cells that are floating around, and we call that reticking. We know that the bone marrow is busy and it's trying to bring up the count and increase oxygenation. This slide speaks to what is necessary for erythropoiesis. The thing to keep in mind is that there are certain key elements absolutely necessary for erythropoiesis or red blood cell formation. So when these elements are not present, the body cannot produce red blood cells that are healthy. So as you see here, there are three elements needed and a fourth kind of sub-element. The first is vitamin B12. B12 is a very large molecule, and we get that from our diet, and because it's such a large molecule, it needs help getting absorbed in the GI tract. Think about what it needs. It needs the intrinsic factor to get transported across the ileum and into the circulation. What type of anemia do we have without intrinsic factor? We also need folate that is necessary for the maturation of our DNA. 3 of our 4 bases, thiamine, adenine, and guanine, require folate. So it's the second most important vitamin for erythrocyte production and maturation because we need it for DNA synthesis. Folate absorption happens principally in the upper small intestine. Folate is stored in the liver, and B12 is also stored in the liver. Now, interestingly, folate deficiency is more common than B12 deficiency, and it occurs much more rapidly. The reason for that is that folate stores can be depleted within a few months, whereas vitamin B12 can take years. And the reason that folate supplements are prescribed in pregnancy is because pregnancy increases the demand for folate. Think about why. Remember, it's needed for 3 of our DNA bases, and the fetus needs to be rapidly reproducing, requiring healthy DNA. This is why pregnant women take folate supplements, which protects against neural tube defects and also can prevent anemia in the pregnant woman. The last thing that is needed is iron, which we are going to speak about more in the next couple of slides. A bit about what it is that the erythrocytes do. As you know, they are responsible for tissue oxygenation, and they regulate the diffusion of gases. Hemoglobin is where the gases bind in the molecule, the hemoglobin molecule. So transport 2 and CO2 away from cells. Transport of oxygen to and carbon dioxide away from cells is a key function. Therefore, you can think about how they maintain normal acid and base balance. And there's a certain shape that's required for proper functionality, which is the biconcave shape and ability to kind of deform reversibly. In other words, they can change their shape into a torpedo-like shape so that they can squeeze into the microcirculation, but that deformity is reversible because they can then return to normal. Here you have a summary of the qualities of the mature erythrocyte. They have no nucleus or organelles, which is why the reticulocyte is not a mature erythrocyte. It still has some nucleic vestiges. The mature erythrocyte also has a 120-day lifespan. This, by the way, is the reason that the hemoglobin A1C test is such an accurate measure of the past 3 months of a diabetic patient's or any patient's blood sugar, because once a red blood cell is ejected out into the periphery, it lasts that long and it can become glycated. And so we know when we're looking at the red blood cells, they've been there on an average of 3 months. The cells are reversibly deformable. Ooh, that's not quite right. They have reversible deformity. I guess they are kind of formidable. They have a biconcave shape, and they carry oxygen and carbon dioxide. This slide shows a series of pictures for you. The first I'd like to point out is the top center, the heme molecule. So hemoglobin is combined of heme plus globin. Heme, that little yellow guy in the middle, that's the iron molecule, the iron atom. That's the atom that binds the oxygen as the red blood cell travels between the lungs and the tissues. The other important thing about heme is that it's pigmented. It is what gives hemoglobin its color, and the color is what we measure with our MCH, our mean corpuscular hemoglobin. So when it's low, we know that there's not enough of that pigment, and so we know we've got most likely an iron deficiency. Our cell is going to be pale. We've also got pictures that show the reversible deformity in the bottom left that show the cell kind of making that little turn at a bifurcation. You see the normal hemoglobin molecules in the section on the right, and so this really kind of shows what's happening. Here you see the basic cause of anemia. You've either got a decrease in production or an increase in destruction that can happen through the ways that are listed below. You can have blood loss. The most common times that we may see that are in the situation of a hemorrhage, those of you in the acute care setting, or in my setting, the most common time that I see it is in the perimenopausal woman who's having heavy periods, and so she's losing blood each month faster than her body can produce it. The other time that we might see it is in a slow, gradual situation in terms of a GI loss, whether it's upper GI or lower GI, loss of blood. But the important factor is that when we see an anemia, we have to first determine the cause before we begin the treatment. Nutritional deficiencies definitely cause it, as they are going to impact production, and we reviewed the elements that are necessary for appropriate deficiency. Anemia also occurs concurrently when we've got an inflammatory process or a malignancy. Oftentimes in malignancy, the treatment can be contributing to bone marrow depression, but inflammation definitely also impacts production. It impacts the cytokine signaling that's required, and there is the one type of anemia category called anemia of chronic disease, and this is contributing to that. We can have a malabsorption syndrome in terms of GI impact, people who've had gastric surgery, and it can be an inherited deficiency, as with sickle cell, thalassemia, or other hemoglobinopathies. Last slide, we have our definitions here. There are several things listed. Ferritin is a key one for you. That is the iron storage protein in our cells. So that is measurable, and that's a way for you to really gauge what's going on. You can have a patient with a normal hemoglobin, but with a low ferritin. I frequently measure this in my perimenopausal women who are having menorrhagia. They are losing blood, they're telling me they're fatigued, and I've learned over time that just getting a CBC isn't enough, because I would have a normal hemoglobin, but it was only part of the picture. So I now order a ferritin, and it's very telling, because you can have a normal hemoglobin, however, month after month the body is dipping into the iron storage, and so the ferritin level can get low. The lowest normal end is 5, but the high is 270. So when a woman is, like about 50 or less, you know that their iron storage is being depleted. MCV is the volume. MCH is the corpuscular hemoglobin, the color. Those two are called the indices. The MCV tells you the size, and the MCH tells you the color. For instance, iron deficiency anemia is a smaller size, which we call microcytic, and paler, smaller size, lower MCH. Erythrocytopenia, penia and ptosis are two terms to know. Penia, in Dr. McGrath's way of learning and remembering, rhymes with tenia, which means teeny or tiny, or it's decreased, whereas ptosis kind of rhymes with mostest, which means you have more, you have an increase. So when you have reticulocytosis, you have an increase. And remember, we talked about what reticulocytes are. Those are those immature cells. So when you have a reticulocytosis, the body is putting out higher levels of immature cells to respond to some type of a problem. When you have an erythrocytopenia, what do you have? Thank you. This is the end of our second video.